Hello guys, welcome to our first NCLEX practice session. This is part one of many more to come. I have a combination of a few easy questions and also some more that will cause you to do a little bit of critical thinking because that is really necessary in our environment as a nurse. A lot of things in the past were done by doctors and not really nurses, but a lot of the doctor stuff is now done by nurses. So critical thinking skills is really important because you are the eyes and ears and everything for that doctor. And especially if you ever work on a critical care unit or if you decide to go into that right after graduating. Some hospitals now are actually letting students, fresh new grads, do that. In the past, that was unheard of. You have to have like at least a year of experience on another unit, maybe even two, before they even think about letting you be in critical care. But nowadays, with the shortage being so bad, they will allow you to go into critical care. But of course, your training will be anywhere from 6 months or longer, because it's all about patient safety. And also you also keeping your license safe as well. So you are the eyes and ears. And in the critical care environment, it may be too late to rush to the phone. Oh, doc, this is what's going on. What should I do? By then the patient could be dead. So critical thinking is key because you are really the eyes and ears and you're kind of serving as doctor. If you think about it, using the protocols and stuff that they've already preset for you, but you have to make the decisions right on the spot to use whatever protocols that's already been pre-aligned with that particular unit or that particular hospital that's already been approved by the doctors and the med team, etc. So that, because every little second counts and the patient's life is at stake, especially in a critical care or trauma facility, neuro ICU, those kind of things, all of which I've worked at. So I'm telling you from experience, this is important. So I threw a few critical care questions in here as well. Okay, but let's keep it simple at first. Let's do number one. Your patient is ordered for wound vac therapy. The nurse understands that a wound vac works by which of the following? Is it A, treatment that allows drainage to collect in a plastic container as the wound weeps? B, a treatment that uses controlled negative pressure to assist and accelerate wound healing? C, a treatment using 4x4 sterile gauze to absorb the wound drainage, which will collect in a plastic container when saturated? Or is it D, none of the above? If you chose B, you are correct. Negative pressure wound vac therapy is a treatment that uses controlled negative pressure to assist and accelerate in wound healing. What this actually does to the wound, it causes like a suction. Imagine vacuuming a floor, okay? Vacuum either kitchen floor or carpet floor, doesn't really matter. And imagine taking that same vacuum or a vacuum type effect and putting that against a patient's wound. Oh my God, their open wound. Okay, imagine that sucking on that wound. Now, I'm speaking also not only from experience in terms of nursing, but of experience as being a patient with a wound vac. I had my first son. I had a C-section and it didn't heal properly and the wound dehisced, which is pretty much that the wound, the closure area opening up. And it's not supposed to open. It's supposed to be healing. I was already home, out of the hospital. And I had two decisions to make. I had to make either the decision of, the doctor gave me the choice, because I was a nurse. You can either do the 4x4 sterile dressing gauzes, soaked with saline, and do wet to dry dressing changes for up to 6 months, because literally the wound was so huge. I mean, imagine the baby, the area that baby took up. You literally could put your whole arm inside my belly. I mean, sound a little graphic, but literally I could put my whole arm in my belly. That's how much space was there. just open space. It had not granulated with tissue yet because I hadn't healed. So I could either go by stuffing the wound with a bunch of 4x4 sterile gauze and doing wet to dry wound dressing changes for up to 6 months, because that's about how long it would take using that method for all that skin to granulate back in. Or I could be a patient of a wound vac. And the brand they had was KCI. I know you still see KCI brand a lot in a lot of the hospitals. And people go home with those as well, because that's what I did. So anyway, the difference between the 4x4s, which would have healed the wound fine, it would have took about 6 months or so, versus the wound vac. The wound vac healed me in literally 35 days because it caused a suction on that wound. So let me describe how that is with the patient and how it was with me as well, since I was a patient. So you have in the kit, when you have put a wound vac on a patient, there's like a black charcoal looking gauze, okay? That gauze goes inside the patient's open wound. And when it's cut and trimmed appropriately so it'll fit inside the wound, not hanging on the outside of the perimeter of the skin, because you don't want it touching the really good skin. You really want it inside the wound. And then on top of that spongy material goes a little teeny little plastic suction cup. It looks kind of like silicone. Suction cup over top of that sponge. Then over top of all of that, and that suction cup is also hooked to a hose, by the way. Then you have a clear dressing that goes, and it comes with the kit, a special dressing from KCI or whatever wound vac company you're using. And that plastic shield goes over top of the vac and the spongy material. And it closes all that inside, so that way when you turn on the suction machine, and it's going to be set to the PSI based on what your wound nurse ordered, because usually it's not the doctors that's ordering that. It's usually the wound nurse who specializes in that, and she lets the doctor know, hey, this is what I need done, this is the order I need you to place, and the doctor listens to her recommendations, because that's her area of expertise, the wound nurse, okay? So whatever parameter she set it for. So once you turn that on to the proper suctioning or the proper PSI, that it'll be just like a vacuum, like you're vacuuming on the floor, suctioning up, sucking on that wound. And while it's sucking on the wound, it's collecting and pulling out any drainage that wound is weeping out. And when it's pulling and pulling, it also stimulates that wound to start to granulate and granulate more and more cells, which does what? It causes the cells to divide, multiply, and grow and granulate and fill in that area quicker than it would the wet to dry saline dressings with the 4x4s. 4x4s have that same effect, but it's a slower way for it to be wet, then it gets dry, then it's granulating a little tiny bit, and little by little, month by month. That's a long time. Where this vacuum is causing the wound to, for the cells to grow faster, divide quicker. So that whole suctioning effect causes that. At the same time, it pulls out all that drainage. And once that canister that's attached to that wound vac gets filled, the canister gets changed. Usually, most patients have like a weekly dressing change with the wound vac. The wound nurse will decide how often the dressing gets changed, and usually she's the one that does it. Or if you have people that knows how to do it, such as myself and other people that's been trained to do it, we do it too, but still following the wound nurse's parameters in which she had the doctor actually put into an official order. Okay, so the point is it heals the wound faster. Oh, it's awesome. God, I wish I had invented it myself. It works beautifully. Literally in 35 days, I was completely healed. It was a little teeny little spot. Imagine an area big enough to put your whole arm in has shrunk down to a spot no bigger than a little 1/4 of an inch that I could just put a little standard Band-Aid over top of it. That's how small it was. Just like a little tiny scab for a little Band-Aid. in 35 days. Absolutely amazing. Ever since that experience, I've always been, a big believer in wound vac therapy. Okay, so that is the answer, and that's a little bit of information. Brought some of my personal stuff in there, explaining how well this thing works. And just in terms of the patient, what is the patient feeling with this? Because I'm using myself for an example, because I was the patient. It actually feels just like someone just constantly sucking on the area. It's not a painful thing. It is not painful. It feels kind of weird. It just feels like someone's sucking in the area. But it's not painful. Believe it or not, it's not painful. I was actually shocked. I was ordered narcotics, actually, when I had that. And I refused the narcotics. I told the doctor, I don't want the prescription, because I was breastfeeding my son. And when you breastfeed a child, the child is also getting some of those narcotics that you are ingesting. The child is getting that too in their milk. And I wasn't going to have my son doped up with any kind of narcotic medication. So I chose to just say, I'll take some Tylenol if I need to, or some Motrin, but I'd rather not take anything because I don't want anything affecting my son. And he was a preemie on top of that, so I really didn't want anything hurting my child. So I just dealt with it. And the only discomfort really is when it's time to change that dressing, and you take the plastic cover off. It's like a sticky plastic film, and then the nurse, well, I did it for my nurse, who was my home care nurse, but the nurse actually goes and slowly pulls out that sponge that's in the patient's wound. Keep in mind, a sponge has little holes and stuff in the sponge, just like a typical sponge you would use to wash your car or wash dishes. Picture a sponge with little holes all in it, because that's what a sponge looks like. So that same kind of sponge, similar type sponge is in the person's wound. Remember, suctioning was happening. So what's inside all those little holes? I mean, not trying to be graphic, but you need to know this is what you're doing. This is part of your career here. So graphically, you have patients, their skin and part of the wound is all stuck in between the holes of those sponges, right on the bottom of the sponge where you're taking out of the patient's wound. So you have to slowly release that. You can't just rip it out. You have to slowly take that out. Usually with most patients, it's best to pre-medicate them about 30 minutes prior before doing that procedure. With me, I kind of did my own thing because I was already a nurse. And when my wound nurse came over to my home, I pretty much did her job for her. I had already taken my sponge out because I was slowly taking out little by little as much as I could handle it and bear it, and had it like laying on a towel so she could write down the assessment of how much drainage it was and those kind of things, because she still had to document that kind of information in her notes. And I didn't want to mess up that for her. But usually you take that out, you pre-medicate the patient prior to doing it, because it is very uncomfortable. For some people, it could be painful. Women tolerate pain a little bit better than men. So with me, childbirth was more painful than taking out a sponge. So yeah. So, but that's how that works. And and the great thing about it, when a new sponge is put in, use a new sponge is a smaller size than the previous, because your wound has already started to granulate and fill in. So each time you put a new sponge in every week or so, usually pretty much every week, the wound is getting smaller and smaller and smaller, till like mine was, it got to the size of a little teeny 1/4 inch. You could just put a little Band-Aid on it and it healed on its own at that point. Okay, so that is the answer. B, negative pressure wound vac therapy, using that controlled negative pressure to assist and accelerate in wound healing. And I just gave you a lot of kind of graphic details so you can get a better picture of what's really going on in that wound and why it's healing so fast. That suctioning from the vacuum is causing that. Okay, so the other questions I won't go into as much detail, but since that was a personal one for me, since I experienced it and lived it, and it was wonderful, because I would have been out of work for 6 months, and at the time I was a breadwinner for my family, and if I was out of work for 6 months, mortgage wouldn't have got paid, et cetera, et cetera. Okay, so it's a great thing that it healed me literally in 35 days. I was back to work, and it was wonderful. So now my husband was very happy as well. So let's go on to number 2. Question number 2. When caring for an intubated, critically ill patient, a family member can be included in which of the following activity? Is it A, helping the nurse change a dressing? B, helping with the patient's oral care? C, helping the nurses with bathing the patient? D, passive range of motion? If you chose D, passive range of motion, this is the correct answer. And I know many of you might be saying, well, why wouldn't C be the right answer, helping the nurses with bathing the patient? If it was, remember, the key thing is we're talking about an intubated, critically ill patient. So if we were discussing maybe a medical surgical patient on a regular med-surg unit, or maybe even an IMC, a step-down unit, or regular PCU, a telemetry unit, yeah, maybe. But we have someone who's intubated. A lot more serious stuff going on. You really don't want the family member moving a patient a certain kind of way and things of that nature. Tubes could get dislodged, etc. The patient could die. So that would be better for a lower type unit, not the critically ICU, neuro ICU, MICU, SICU, trauma unit type unit. So let me explain briefly, not as long as number 1, right? Thank God. Okay, so with the reason why we would pick passive range of motion in this case is because if you're dealing with the oral care of an intubated patient, that should be performed by the nurse or the respiratory therapist because they can maintain the safety of that ET tube and assess the patient's oral mucosa, because a lot of times the mucous membrane in the mouth can have some kind of breakdown. It can be dry. It could be really wet and with a lot of not only phlegm, but other mucousy substances that needs to be suctioned while you're doing the oral care. And, we're using certain chemicals and things to keep the mouth as clean as we can. That's not something we really want the patient doing. The patient's family member doing. Okay, also, again, the bath is important really for the nurse more so to do. Usually the nurse has another nurse in there helping her, which is why I said helping the nurses with bathing the patient. Because usually it's not one nurse. Usually we get another ICU nurse in there with us and to help us to turn the patient. Usually those kind of units don't have a lot of CNAs. So usually we grab another ICU nurse and we do our baths together and take turns doing each other's patients. But that's an important time for the nurse to really assess the skin. Why is that? Because remember, the patient is knocked out cold. We got them on propofol and other things to keep them knocked out so they won't be taken out their trach. And literally, the skin, even though we're turning the patient every 2 hours, some people's skin is more fragile than others. What if there's a little bit of redness in one area that can cause more breakdown and more breakdown? So the nurse wants to assess every little spot on that patient, from the back of the neck, sides of the face, the arms, especially those bony prominences like the elbows, the knees, and hips, and all those areas. And if you have the wife or a mom or someone doing the bath, they're just, they're bathing the patient, they're happy to be in there with their family member, but they're not really maybe looking for key things that you're looking for to prevent important stuff like skin breakdown. Okay, so that should really be done by the nurse. Moving forward, some patients don't even like being bathed by family members on top of that. So let's say the patient is partially woke. That might be uncomfortable for the patient, especially if you're a grown man and it's your mom in there and you're like, oh my God, I don't want my mom bathing me. Oh my God, she hasn't seen me naked since I was in a diaper. So that might be uncomfortable for some patients. Some patients really don't like that. If it's a family member maybe helping wash their face, Yes, but keep in mind, in this situation, we have someone who's intubated. Do we really want the family member washing the patient's face and then accidentally dislodging the tube, and next thing you know, it's cold blue, and yeah, it's a big mess? No, please don't touch the patient's face. Let the nurse do that. So the only thing they really can do is the passive range of motion, maybe holding their loved one's hand, moving their arm up and down, moving their hand, helping them flex their fingers, and things of that nature. Again, passive range of motion is when that person is actively moving that patient's foot, arm, leg, fingers, things like that. The patient doesn't have to participate because it's not an active range of motion. So D would be the only best answer in this scenario, because we're dealing with a intubated, critically ill patient, not a regular medical surgical patient that's laughing and talking and can walk and all that stuff. Okay? All right. Let's go on to the next question. Okay, number 3, our last question for this session. Your patient is recovering from laparoscopic gastric bypass surgery. Which of the following complications do you anticipate once the patient starts to eat? Is it A, the patient will experience dumping syndrome? B, the patient may go into acute renal failure? C, the patient may develop type 2 diabetes? Or is it D, the patient may develop pancreatitis? If you chose A, dumping syndrome, you are correct. 10 to 50% of gastrointestinal surgeries, such as gastric bypass, for example, result in some form of dumping syndrome. This condition is also known as rapid gastric emptying, as it is characterized by rapid emptying of the stomach of all of its contents into the small intestines. This occurs when food, especially sugar, moves from the stomach to the small bowel too quickly. This leads to large amounts of undigested foods entering the small intestines and increased propulsive motility, which results in loss of nutrients and impaired bowel function. Keep in mind now that, remember, if you picture the intestines, remember it's constantly moving. That motility is happening. That motility is what moves that food from that stomach area all the way through to the anus. So literally, it's just picture something just constantly moving. I'm sure you guys have seen this in your anatomy physiology courses, looking at that intestinal wall, pulsating and moving food along. Okay? So imagine large amounts of undigested foods entering that small intestines. Remember, a lot of this stuff was supposed to be broke down, in the large intestines first before entering the small intestines. And that's now resulting in a loss of nutrients and impaired bowel function. Okay? Now, acute renal failure and diabetes and pancreatitis are not common complications of this type of surgery. Okay? Short and sweet. So I hope you guys enjoyed this session. I hope you learned a lot. Shared some of my personal information there. Maybe a little too much info for some. But I want you to get a better view and understanding on how, certain things work. And if you answered everything correctly, good for you. Wow, great critical thinking skills. I'm so proud of you. And don't forget to like and subscribe. And if you have other nursing students, or even just people who want to know more about health, or they may have a family member that's in the ICU and that's intubated and want to know, well, how come I couldn't wash my husband or my family member? What's their problem? You might want to share this video with them so they can understand that you're just protecting their loved one. They may have a better understanding if they hear it coming from me as opposed to coming from you, and may take it a little personal. So like, subscribe, and share this video with others, especially even some med students out there who are, freshly new doctors and may want a better understanding of a few things. This will also help them as well. All right, guys, thanks for joining me, and I will see you next time.